Hi, everyone. Welcome to this session about unknown ataxia with family history. So Dr. Yasushi Kisanuki obtained his MD from the University of Tokyo. After his research training at the University of Texas Southwestern Medical Center in Dallas, he completed his neurology residency at the University of Michigan. He joined the Ohio State University Wexner Medical Center as an assistant professor. He is currently a clinical associate professor in the Department of Neurology at the Ohio State University Wexner Medical Center. With his expertise in neurogenetics and the management of ataxia and spasticity, Dr. Kisanuki organizes several specialized clinics, including a multidisciplinary cerebellar symptom management clinic, a neurogenetic disorders clinic, and a spasticity clinic utilizing intrathecal baclofen pumps. He also serves as the residency program director for adult neurology residents. His research interests are centered on developing therapies for genetic cerebellar ataxias, primarily lateral sclerosis, and other genetic disorders such as hereditary spastic paraplegia. Recently, Dr. Kisanuki played a pivotal role in a multi-center phase 3 clinical trial led by the FDA, leading to the FDA approval of chenodeoxycholic acid for the treatment of cerebrotendinous xanthomatosis. And with that, Dr. Kisanuki, the floor is yours. Thank you for joining us today.
Thank you very much for your kind introduction. So my name is Yasushi Kisanuki. I'm from the Ohio State University Wexner Medical Center. So today I think we like to talk about the history of the unknown ataxia with the family history. And so I'm going to say that how that this particular group of patient or family has reached to. So obviously the patient going to have a sign and a symptom for the ataxia, but then that there's a family history. And so the question, like when it comes to unknown category, it can be probably two different populations. One is that those who already underwent actually the genetic testing, but the test result or interpretation was either negative or inconclusive. So that's why that it is still categorized as unknown, or just simply put, the genetic testing was very difficult to be obtained. And so despite the family history suggests that underlying genetic disorder, but because of some access issue that, these patients may not have the specific diagnosis yet. So I think that I'd like to just kind of briefly overview the, so-called, what do you mean by family history? And I think I'll try to just kind of go to the very basic. Maybe some of you might already heard, and so may not need a detailed explanation, but because this is a gear for everybody, so I like to just go through this. So when we say genetic disorder, we usually think about different inheritance type. So I'll just kind of lay out the typical ones: autosomal dominant, autosomal recessive, X-linked, mitochondrial, which I mean by the mitochondrial DNA variant derived inheritance. And I'm gonna also touch base with the penetrance issue. So let me go through this. So the autosomal dominant disorder, this is like a typical family tree. So in the genetic field, that the square is usually a male, and the circle is a female. This is just how we kind of pick the symbol. And so in this particular diagram, that you can see who might be affected and who's not affected. So as you can see, there's some succession of the affected people across the generation. And theoretically, this is a 50-50 chance of the inheritance to go into the next generation. Now, on the other hand, the recessive inheritance, this is like another typical example. You might see at the same generation level, in other words, like siblings, but then that the parents usually don't show any symptom whatsoever. And I didn't really draw the below the generation, but usually below the generation of the affected patient may not develop any symptom at all. So basically, you can only see in the one generation, but the above and the below generations are not necessarily affected. Now the X-link, it's a little bit more complicated. So it's a little bit a busy slide here, but what I try to point it out is two things. One is that if you see the dot on the female side, that means carrier. So basically that because the underlying gene is located on the X chromosome, which is a sex chromosome, and so typically there's a strong tendency that the male patient is going to be symptomatic. On the other hand, we sometimes do see women can still have a mild presentation or can be just asymptomatic. So that when it comes to the X-linked disorder, the women can be very kind of like not so straightforward in terms of the presentation standpoint. The reason why that the male tends to become symptomatic is as the male, we only have the one X chromosome. So we don't have a backup. So that's one of the main reasons. So you can see there's no transmission from the father to the son, because from the father to the son, father's X chromosome is not going to be transferred to the son. He only can transfer the Y chromosome to the son. So let me go into the next one. So this is another example of the mitochondrial inheritance. So the mitochondrial DNA is somehow, we don't know the reason, but exclusively inherited from the mother to the next generation. So that's why that you see the affected woman gonna transfer the next generation for both children, but then that from the father you don't see any transmission. That's just a unique feature of the mitochondrial behavior. So I mentioned about the penetrance, what the penetrance means. So when we say penetrance, it means like a complete or incomplete penetrance. So what the complete or 100% penetrance means. So let's say you have some causative gene which has been confirmed as a pathogenic variant, but then that those who have the DNA change, it kind of match with the onset of the symptoms. So that's what we mean by the 100% penetrance. Now, of course, there are a lot of genetic disorders which has an incomplete penetrance. In that situation, if you just follow by the DNA level, you might see let's say like autosomal dominant inheritance I just showed you earlier. You might see actually the succession of the genetic like a variant, but then that when it comes to the symptom presentation, you might sometimes see a skip generation. In other words, DNA does not always match up with the symptom manifestation. So the incomplete penetrance disorder can be very tricky because we cannot completely rely on a genetic test result to predict whether such person is going to become symptomatic or not. So now, of course, today's topic is unknown ataxia with the family history. So the diagnosis can be very tricky, not so straightforward. So I mean so we still heavily rely on the genetic testing when it comes to try to settle down the diagnosis. But as I mentioned earlier, uh, those who consider to be unknown, like a type or unknown diagnosis with the family history, it could be, gene testing was already applied, but the result was inconclusive, or simply that there's some access problem for the genetic testing by itself. So I'm gonna just kind of go through what's the kind of real world experience on the genetic testing. And I'm gonna talk about why we like to pursue the gene testing and what kind of testing can be available and how important the counseling and some of the cost and the insurance issue. So this topic, unfortunately, I can only speak about the United States, experience. I know that the different country might have a different healthcare system. and the potential insurance coverage issue. So unfortunately, I cannot make a much comment about the other country other than the United States. I apologize for that. And some of the turnaround time, depending on the test you choose. And there's a still limitation of the available gene testing. So why we care about the gene testing? I think I can try to emphasize some of the potential benefit. So first is that clarifying the diagnosis. Even though we are still pursuing the research to trying to improve the new therapeutic options, I still have to say that in order to pursue the research, I think we need to have some definitive diagnosis for the individual patient. Now, I kind of already mentioned the second line, but why do we care about the gene testing? Because having the specific diagnosis can allow these patients to look it up, the relevant clinical studies. So I don't know, you had a chance to look it up, some of the website, clinicaltrials.gov. That's probably one of the very good a resource. Obviously, this website is more geared for the provider or researchers oriented, but you can still type your specific genetic diagnosis to look it up. And then that you can open a discussion with the relevant providers to say, hey, I saw this potential research study. Is this something I should apply for this? And I think this is really helpful, even for the provider point of view, so that we can dive in and look more detail and explain what these technical terms mean to the patient and the stuff. Now, probably the last one is a little bit tricky issue because I mentioned that the issue on the penetrance issue. So it can provide information for the relatives at risk by knowing the specific genetic diagnosis. On the other hand, it can also affect the familial dynamics by knowing these diagnoses. So this kind of somewhat lead to the importance of the genetic counseling component. So speaking of the available testing options, I'll just kind of touch base with just the basic concept. There are probably two approaches. One is a panel. So panel, when the doctor or provider starts saying the panel, that means it's already selected genes. So in other words, that the different company advertise the different panel. So let's say ataxia gene panel. So it varies, very small number of the gene to the quite a large repertoire of the genes. But as long as that they keep saying it's a panel, it's a pre-selected genes. So the advantage is the relatively fast turnaround. And the result's going to be very straightforward because we already know what genes we're going to screen. Now, the somewhat disadvantage, because I'm going to talk about the other approach, it can be unproductive, meaning that you run the testing, but then you just came back with everything they tested did not pick up any a DNA variant, essentially negative result. And I'm going to say that is that really cost effective at the end of the day? So that really depends on the situation. If the panel you selected and you submitted and I still get the diagnosis, it is reasonably cost effective. But then if the panel you selected, submitted, came back negative, then what? Because you already probably spent some money, and then are you going to just keep repeating the other panel? And so essentially, per gene cost is not that very cost effective. That's the kind of whole point of the panel. Now, I'm going to then talk about the other approach, which has become more available for the more patients. So we consider as a comprehensive sequence approach. So you might heard about the whole exome sequencing or whole genome sequencing. So these are using the different approach. I'm going to just try to be relatively simplistic way that essentially we sequence the very large repertoire of the genes, tens of thousands of genes from your DNA. And then that we compare with the so-called reference sequence, which is coming from the previous sequence result from the general population database. And then once you compare between your DNA sequence and the reference sequence, they can try to analyze that if there's any DNA change within your DNA, within your genes. And then that they can further dive into look more detail. So this approach, in a simplistic way, we're trying to find a needle in a haystack approach, essentially. And so the advantage can be very robust, and it can provide a higher sensitivity of detection of the relatively rare genetic disorders. Now, the disadvantage, it can be an access issue, meaning that because the cost can be still high, and some insurance does not necessarily cover this, so that it's not unfortunately available for everybody at this point, unfortunately. And compared to the panel, there's some longer turnaround time. And then that I kind of put as a cons, but it can be, potentially a benefit. But in other words, because we don't necessarily select the genes up front, you might get the so-called secondary finding, meaning that even though we look for the ataxia causative gene, but then you ended up seeing the unexpected other genetic disorders. So the typical example I just have to say is let's say we find out that you have some cancer risk gene, for example. And so if you say this is actually a benefit, so I don't necessarily consider as a disadvantage, actually. If you kind of well prepared, this might happen to your test result. So that's why that anybody who's going to go through the genetic testing should have some discussion about so-called genetic counseling. So I kind of put this in a title, basically. So that counseling should happen before you actually even submit the testing. So you know what you are getting at and what kind of result you like to expect to see. And actually, particularly for the comprehensive gene testing, most companies gonna actually put the option for you to say, do I really want to see the secondary finding? Sometimes you can say, I don't want to see a surprise result. And I just want to focus on ataxia finding. So you can actually request a specific like a report generation during the counseling process. And then that, of course, after you get the test result back, I think there has to be some like a formal genetic counseling as a post-testing period as well, because some of the results are not so straightforward, particularly from the comprehensive genetic sequencing. So I'll just kind of go through some of the cost and the insurance issue because we cannot ignore this component, unfortunately, whether you like it or not. So this is unfortunately only for the United States. I do apologize that I should have prepared a little bit more information from the other countries as well, but I'll just stick on the US situation. So so the Medicare, which is the government insurance, and apply for the above the certain age group population. Unfortunately, right now, when it comes to the gene testing, Medicare is very difficult. So that they do have a flexibility for the cancer genetics, but when it comes to the neurologic genetic testing, it's basically almost no chance for the coverage at this point, unfortunately. Now, the commercial payers, some payers do accept. My kind of personal experience, it's about 30 to 40% of the acceptance rate. And so when it comes to the sticker price, original cost without the insurance coverage, the panel, I think that the ballpark is roughly about 500, 800, like a payment if you don't have any insurance coverage. And of course, if the number of the genes is going to be expanded, of course, the cost can be much higher. Now, the whole exome, whole genome sequencing, I would say the ballpark is about 2,500 or above, depending on the companies. Now the turnaround time, the ballpark like a turnaround time, panel is usually about 6 to 8 weeks, and then the comprehensive testing can be 3 to 6 months time range. Now I'm gonna also touch base with the limitation of the gene testing. So you might hear like, I guess some very inconclusive test result. So oftentimes these are due to the so-called variant of uncertain significance. So what that means by this? So I mentioned that, there's some reference sequence from the population database, and your DNA get analyzed compared to that, and then they see some variation. Now, if this variation is already defined as a disease-causing pathogenic, basically, the positive variation, then we're going to put as a positive. But then there are some situations that you just happen to have a unique DNA change, which we could not settle down whether this DNA change is going to be really causative for your ataxia or not. Then instead of like overcoding, we tend to still keep as a neutral position, meaning that we don't know yet at this point. So that's what the uncertain significance can be. Now, of course, this is we consider as a dynamic interpretation. So in case that we accumulate more other patients unrelated from you and across the globe, and we start seeing again and again those who have ataxia and still have the same DNA change, which belong to be associated with the ataxia causative gene, they could change the interpretation in the future. So when you hear some variant of uncertain significance, I think we have to be a little bit kind of cautious about when this test was done and is there any updated interpretation in the future. Now, the other possible result you might get, and that's why this might be still called unknown, like a type of ataxia with a positive family history, is a negative result. Now, the negative, we also have to be very careful about the nuance. Essentially, it's not equal to the rule out of the genetic disorder. It's just merely stating that up to the capacity of our knowledge, we just could not find or settle down the interpretation to say you have some specific like a genetic disorder. So in other words, even though we already have the Human Genome Project which kind of essentially mapping out all the genes that the human carries, we already put every gene a name to try to make sure that we speak the same language across the scientific field. We don't necessarily understand every single genetic function yet. Of course, that means that we don't know what happened that if some of the genes gonna change the DNA sequence. So that's why this area is a still evolving area. You might hear like we discover a new gene. Well, technically it's a new function of the genes because the name of the genes are already identified. So that's why the negative, we also have to be somewhat cautious about what that means. So that kind of somewhat lead to the next, the highlight of the reanalysis of the previously negative comprehensive DNA sequence data. So most company actually does offer the reanalysis option for you if your previous test interpretation came back as an inconclusive or negative result, because they usually store your original sequence data in their server, and we just need to request to open the case. Now, how often or how interval that you should wait for the reanalysis, that's always some tricky question. I'm gonna say that I might say maybe 5, 10 year might be reasonable, like an interval. I don't usually consider like a 1 or 2 years gonna be sufficient to improve our knowledge base. So I'll just kind of touch base with the clinical care, but most of the clinical cares are still not so different from other defined ataxia, actually. So, this might be probably the repetition of what you already heard, from the other speakers. So I'll just kind of briefly touch base on this. So what age of onset and the typical progression. Now when it comes to any genetic disorder, we consider the age of onset can be very wide range. I don't necessarily, decide like just because patient develop at this age or that age, I might change my opinion to say, oh, you have more likely or less likely a genetic disorder, because on the real world, we see quite a wide range. And in general, the typical underlying genetic disorder, including this particular group of the patient, tend to show the slow progression in general. Now, why that the neurologist is important in this role. So we as a neurologist can define the clinical diagnosis of ataxia. So the word ataxia, I think depending on the provider of discipline, that sometimes use kind of somewhat casually, I'm gonna say, compared to what neurologists gonna use. So that's why that it is important that if you have a symptom or sign questionable for the ataxia, I think it's still reasonable to be seen by the neurologist. And of course, we can potentially set up or introduce a genetic workup and the management of the symptom. And then that I mentioned earlier, but future clinical study gatekeeper role. So I think probably the symptom management wise, I don't think there's no particular extra special information. So, but I'll just kind of touch base typically, quite a number of the ataxia patients do have a tremors, and we sometimes use the medication or the combination of the medication plus occupational therapy referral. And sometimes that the patient can develop the stiff muscle we define as a spasticity, or some pain related to the overlapping neuropathy. And gait and balance is, of course, one of the key symptoms, which is usually, how we're going to try to provide a safety through the collaboration with the physical therapist. And you might have some dexterity issue on your hands. That's often matter of the occupational therapist, the domain. And then that the speech and the swallow function, which are usually addressed by the speech pathologist. So I kind of already mentioned all the necessary disciplines. Now, I do also have to emphasize some of the importance of the social worker's role, because we recognize your symptom can impact your day-to-day activity, but also can affect your, some a work environment, or you might at risk of let's say difficult to continue a line of work. And then that our social workers are usually very resourceful, how to try to transition your, let's say a work adjustment, or even to consider future so-called a disability type of a benefit and stuff. And again, that all these specialist referral can be combined to be done through the multidisciplinary clinic platform. I think that the National Ataxia Foundations are very strong about to promote this type of approach. And they do also kind of solicit a so-called a center of excellent institute who can actually provide excellent quality of the care as well. So I think that's my presentation, and I think the rest of the session will be open for the Q&A, I think. So thank you very much.
So we have an attendee who asks, if I had testing 15 to 25 years ago that was inconclusive, should I see my neurologist again for reanalysis?
So my answer is that I'm assuming that that 15, 25 years ago is going to be most likely a panel-based approach. So that panel means that the company who analyze your DNA do not store your sample, nor the other sequence data, unfortunately. So in other words, that it is not technically reanalysis, but it's actually opening up the new analysis, actually. So that, in other words, that let's say if you like to pursue the more comprehensive DNA sequencing, that's a totally a new order setup. usually through maybe from the different company actually. But I think my short answer is yes. I think I would recommend to open a discussion with your neurologist to say, I mean, should we try to, open up another evaluation for the genetic workup actually. So.
And to clarify, this would involve giving a new DNA sample, either
Correct.
by,
Yes.
depending, this could involve blood, this could involve a cheek swab,
Saliva.
this might be saliva, depending on what kind of company or options that are available from your provider.
Correct.
And then just while we're waiting for folks to type other questions into the Q&A window, you talked a little bit about this multidisciplinary care and how different healthcare providers can work together to help provide support for people with ataxia. Can you talk a little bit more about that in terms of what kinds of support, like a PT or an occupational therapist or a speech language pathologist could provide someone with ataxia that doesn't have a specific genetic diagnosis, but they have a clear clinical presentation?
So actually the strong suggestion is I mean, I bet that the most of the, depending on the institute, but I mean, it tends to be more like a tertiary care center, unfortunately, but that's like where we have more resource available. But those tertiary care center usually should have the well-trained neurodiscipline PTOT. So when we say physical therapist, occupational therapist, I think that hate to say it this way, but the majority of the so-called customers are orthopedics discipline, just in general. So I'm not saying like these therapists are no good. It's just that we need to try to work with the neuro discipline, because there's a special like a training requirement to claim that I'm a neuro PT or neuro OT compared to the other so-called like a more general physical therapist or occupational therapist. And that's what the multidisciplinary clinic is also very strong about this, because they do see these neurologic patients more frequently. So they are very familiar about what kind of like a realistic goal setting and also the practical approaches. And I think the reason why I do kind of promote the multidisciplinary platform is I think that the traditional model is that you see the neurologist clinic and then he or she's gonna say, okay, we'll put your referral to this and that, and then you're gonna end up like going to the multiple different locations sometime, and it can be very sometimes very time consuming, or actually a lot of resource intense like an approach actually, because let's say you have a hard time driving by yourself to get there. I mean, I'm talking about more United States situation, but some of the other country might have a better public transportation, but when it comes to driving here and there, it can be very tasking. But then the multidisciplinary, on the other hand, of course, a visit can be longer compared to the regular clinic visit, but you get to see pretty much everybody, like all at once. And then the other beauty is when we refer to the physical therapy, occupational therapist on the separate encounters, we just get the written report. I mean, they might sometimes send us some feedback, but of course, a written document is still relevant, but it's much better to see in person, and then that we can talk each other, say like, hey, I just saw your patient, and then like, this is what I think. And I
Because
think
more of a conversation.
correct. And we do have like a so-called roundtable discussion after we finish seeing the like a so-called like a group of patients in a day, I mean in a half a day, let's say that way. So then that discussion is actually very, very fruitful. I also, I mean, start developing my, still like a starting a process, but multidisciplinary clinic. And I noticed that there's a tremendous benefit, even for the provider side.
Mm-hmm.
I think most patients who participated to this clinic also appreciated how they kind of get a very immersive experience. And we also invite the social worker during the table round discussion so that we can kind of go over I mean, is there some like a social situation that we need to address or not? And I think that live like a discussion, even as a post like a clinic like a discussion is very, very useful. and we can try to improve just like a more communication and the quality of the care.
Thank you for sharing your experience with this and for clarifying that just like how MDs can specialize in neurodegenerative disorders or neurology, that PTs, OTs, and other healthcare professionals can also do the specialization and that how you can work together. That's very cool to know. Our next question comes from an attendee who writes, I know PT and OT might or can help balance and gait issues, but currently, are there any medications that might also help with balance or gait symptoms?
So this is I do have to admit that we're still quite a behind. I mean that in terms of like a real like implication of the how we can try to improve this fundamental, most probably the difficult symptom actually when it comes to the ataxia patient because most of them they do have a very good strengths, but they just don't have a good coordination to keep the balance on the gait. And I think I don't think we have really come up with a very kind of like a excellent medication to say, hey, you take this and your balance is gonna get much better type of deal, unfortunately. So we understand that compared to the other, let's say like a neurology field, that you might hear more and more like a breakthrough or potentially excellent medication in a different disease, but ataxia we still experience that, I mean, we have not really come up with the so-called like a blockbuster type of medication, unfortunately.
As a follow-up question to that, are there any sort of, for lack of a better term, secondary symptoms that someone who has ataxia may be experiencing that could be controlled with medication, such as tremors, spasticity? Are there medication options for those kinds of symptoms?
So I think that we do still use the available symptomatic medications. For tremors that they know, we often use the medication such as like a beta blocker, propranolol is an example, or primidone. That's actually the very old seizure medication, but we often use that for the tremor management. And there are some other options available, like if those medications are not really fruitful. The spasticity, we use the muscle relaxant just in general. And again, so like some of those symptoms can be still reduced, or I'm gonna say trying to make it easier for you for the day-to-day activity. But I understand that the tremor medications are still, I'm gonna say not so optimal compared, I mean, because these medications are developed for the different type of tremor as a background. And we just kind of utilizing it for the cerebral like ataxia management. So response can be still not completely satisfactory, I have to admit.
Well, that's good to know. Our next question is around genetic testing again. We have an attendee who's asking if you get a reanalysis of genetic testing, is it possible to get a discount on the test in terms of the price?
Oh, so that's a good question. So I try not to be like, I'm not like a particularly like, advertising specific company or anything, because that's not just my point here. But I've been working with the Variant Techs. That company actually, I think is more, I have somewhat like a little bit strengths over the ataxia genetic testing experience compared to the other vendors. And because they do include the SCA27B, for example, and also the RFC1 gene testing as part of their repertoire of the ataxia gene testing. So my understanding is that if you had analyzed through their company, and then, of course they keep the data, you can request a reanalysis uh, it sometimes can be very free actually. Like, it's just that I don't know the exact pricing to be honest with you, but they do offer quite a discount for the reanalysis actually, because I mean, the first analysis, I think either you went through the insurance coverage or you might have to pay some of the cost, but they do offer the reanalysis at a much more reasonable option for you. So, but that's why that I kind of mentioned earlier that interval should be carefully considered because you don't want to just kind of do it after 1 or 2 years, because then you're not going to get much like an improvement within such short period of time.
So what I'm hearing is check with your neurologist, check with the company that you got your genetic testing through to see what their policy is.
Right.
And if you are looking for different companies that provide ataxia genetic testing specifically, we do have a resource available on our genetics info page on the NAF website. I'm going to ask my colleague Tanoa to drop that link in the chat for anyone who's interested, if you'd like to learn a little bit more about the options that are available to you.
I think a NAF website has a good resource about that, actually. Yeah.
And then our next question comes from an attendee. It's a double barrel question, so 2 for 1. We have an attendee who asks, is there anything that we can do to protect the Purkinje cells in the cerebellum to improve symptoms? Or alternatively, is there anything that can damage Purkinje cells that we should avoid?
Okay, so I can answer the latter one probably more easily. The first one, we still have a difficulty. I'm gonna say that way, okay? So the latter one, how can we try to, like avoid or, not to accelerate the damage to the cerebellar Purkinje cells? So probably the most notorious one is the alcohol. We understand that, alcohol can be socially enjoyable, but I think that unfortunately the alcohol does suppress the function of the Purkinje cell. So that's why that, when you, let's say, see the police, trying to do the straight walk testing, that's basically because let's say, when you get intoxicated, your cerebral functions may temporarily coming down. So they use that technique to screen for the people with severe like alcohol consumption. So, but again, that if you repeatedly expose alcohol with the very high content, that actually can accelerate the damage to the Purkinje cells. And likewise, we also noticed that opioid, I know probably this audience is not going to abuse the opioid, but I just have to mention that I do see cases of the opioid overdose actually can trigger the major damage to the Purkinje cell. So these are, of course, I think a latter one is probably not really relevant to this particular audience, but I just have to say I see really severe case of not even a genetic condition. It's just that just straightforward ataxia presentation after the overdose. And so now I think, of course, if you are deficient in a certain vitamin level, like let's say vitamin E is probably the most famous one, but the other vitamin B, like a B12, for example, these things can, of course, influence the function of the Purkinje cell or just like the nerve cell in general. So we don't recommend like a very skewed diet or certain deficient diet. That we always recommend to eat a very balanced diet. And we don't particularly recommend like you need to take the extra supplements, but you don't want to make yourself on a certain deficiency in a certain vitamin levels. Now, the first question, I wish we can come up with a much better solution here. I don't think we have a particular like a good solution about this, how we can try to prevent damage to the Purkinje cell. Now, obviously that there are some, like you probably heard about this upcoming potentially to be approved, I hope, that the medication called troriluzole. So troriluzole we consider as a neuroprotective medication. So that's why you probably heard about some like study result that which is a little bit kind of probably the first like potentially good news for this ataxia community, even though it's not like a wow medication, but there's still positive result. So
It's like you knew what the question, someone had just submitted a question around troriluzole and explaining what that does. So you've already answered that. But we do have a follow-up question around opioid usage, where we have an attendee who shares that they have, due to an injury, taken one pill of this, and they're wondering if that would be risky for the
No, that's not
cerebellum.
gonna, no. I'm
So in
talking
terms, you would
about
need to have
like,
chronic
I'm
overuse.
sorry. I should be more clarified about this. I'm talking about like a real abuse level, meaning that then you start to inject the opioid to yourself, and then that you pretty much lost the consciousness, and you're gonna be in the hospital or something in the ICU because you are not waking up. That's what I'm talking about. I'm so sorry that
No, that makes
all like
total sense.
you
If
got
you're
the
using this under the prescription and advice of a medical
right.
professional, they'll be
That's
doing
not gonna be
the
a
math needed to make sure that you're still safe.
right. So sorry about this. I mean, I don't mean to, scare everybody. It's just that I'm talking about like a real overdose, like a very symptomatic overdose. Yeah.
Oh, that's good to know. We have an attendee who asks, how do I find a neurologist? She shares that she's on Hawaii and she's having a hard time finding someone. Do you have any advice on how someone they could find a neurologist who has expertise in ataxia?
That's a good question. I mean, I'm sorry that I'm originally Japanese, but I should know a little bit better about the situation in Hawaii, but I don't know specific provider. I do apologize, but um, I mean, does the NAP have anybody in the Hawaii area?
That we do. So we do have a list of ataxia clinics
Okay.
worldwide, primarily in the United States, although we're increasing our network elsewhere. This includes both clinics that are part of an Ataxia Centers of
Okay.
Excellence
Okay.
program, which includes like multidisciplinary clinics, but also smaller ataxia clinics, movement disorder clinics, that movement disorder clinics don't specialize just in ataxia. They serve people with a variety of movement
Yeah.
disorders, but we list clinics that we know they've seen ataxia patients. So please free to reach out to us. I know a few folks, not off the top of my head, but we've had connections in Hawaii before. So please send
Okay.
us an email to research@ataxia.org. For these sort of more specific questions, it's a little bit easier to answer one-on-one. So please reach out to us. We'd be happy to help you.
Right.
Our next question is a clarification question around language. We have an attendee who shares that I was diagnosed with SCA27B 2 years ago, and it was a
Okay.
panel test done at the University of Chicago. I am 67 years old. To be clear, is this considered a late onset ataxia? Not sure if that's the right verbiage.
So well, okay. Okay. So I know a 67-year-old does not, well, does have a lot of meaning of it. So in the wording of the ataxia onset, I think a 67-year-old is technically considered as a more later onset. That doesn't mean you're old, okay? I just want to clarify this. It's a grand scheme of like a age of onset. Like, we consider, age above, 60 or 65 and above. If that's what you start noticing the symptom, I would still consider as a late onset ataxia because we do see, much younger onset, like in general, like, some of them actually starting the symptom in the pediatric phase. So, so that's why that, you know, I understand that you might feel like, am I that old? But late onset is just merely in the spectrum of the ataxia onset.
And then just to clarify, if we're talking about late onset as that term, what other terms are used to describe sort of the age of onset of symptoms? There's early onset, there's late onset. What do we use to describe things in the middle? Is there other terminology that people may hear when they go
Usually we
see their
only use the
neurologist?
late onset. I don't think we use the word like early onset, just in general, because, like, for example, like Friedreich ataxia, for example, these are, quite often that the pediatric, like, or like a childhood to adolescence onset of the presentation as a most of the time. So I don't think we use like early onset just in general because of the historical, like, discovery of the very specific type of genetic, ataxia. I think that we use the late onset because partly because we have some biased opinion, which I already told you. I don't want to be so like discriminative about because of the age thing. But I think in general, clinician tends to have a biased opinion that, oh, you're like over 60 or 65. oh, do I need to consider a genetic disorder? My answer is yes. Always we need to think about it. But I think that's not completely shared across all the discipline. So maybe that's why that this late onset ataxia word kind of start to kind of attach to this. That's just my opinion.
Well, it's very good to know. And then just a clarification question, because we get this question all the time here at NAF. What do we mean by onset? What is there a specific symptom that people should be looking for that they should count down? That is when they had onset. Is it balance? Is it eyesight? Is it speech? What do clinicians mean when they use this terminology?
Onset means any relevant symptom related to the ataxia. So it can be anything, actually. Some people might start feeling like, I don't know why that, I cannot really, like, let's say, I have a hard time to track the moving target as a visual symptom. That can be a first symptom. And if that's really happening, let's say 5, 10 years ago, we consider that's the onset. So onset means just merely where the symptom gets started from the patient perspective. Because we don't do MRI for everybody, right? That for no reason. So we have to go by where the symptom began. And I think we as a neurologist, I mean, when the patient came in with the question for ataxia, we tried to basically screen question like what kind of symptom you had from the first like a time if you go back. And sometimes it can be very difficult to define, like where is actually the beginning part? Because sometimes the symptom can be very gradually developed. But then at some point, I think most patients can still say, I think this is my first symptom. Like I start losing the balance, for example. Like where you kind of started off from what you consider as a asymptomatic phase to symptomatic phase, even a subtle change. I think that we consider as an onset.
Thank you for explaining that. Our next question comes from an attendee who shared he's recently been diagnosed with SCOT27B through a program at the University of Chicago, and they're offering free testing to his family members at no charge. He's wondering if there's other sort of free genetic testing programs for other types of ataxia at other facilities that you might be aware of.
I think doesn't that NAF had some program for the SCA SCA 1, 2,
We do have a free genetic testing program for SCA 1, 2, 3, 6, and 7. To
7, right?
qualify for that program, you need to have one family member who has already received a genetic diagnosis. There is also, off the top of my head, a
The
free
free.
genetic, there's a free genetic testing program for Friedreich's ataxia, not run by us, but there's information available on our website. But I can't think of any other ones.
I don't think no other company or vendor can offer the other type of genetic testing at this point, though. So, but this goes back. I just have to say, it's a kind of chicken and egg discussion, unfortunately. That's why that I'm not really satisfied by some of the insurance statements saying, oh, you guys don't have any treatment. That's why we don't cover this. I'm gonna have to say, look, if we can do the research, if we can try to get the new potentially like a disease modifying therapy, like a Skyclarys for the Friedreich ataxia, the manufacturer or even like some other company might actually start to potentially offer the testing. So I think that that kind of somewhat to drive like how we consider to improve the access to the genetic testing. Because I know that some of so-called unknown with the family history is purely just because of the access issue. And we try to improve this, but we're trying to do, day by day through the, research and, trying to, be an advocate. And I know it takes time, but I think that this is going to be still the way to go.
Definitely a chicken and egg problem there. Our next question comes from an attendee who asks, why do you need an MRI? Are changes in the cerebellum seen on MRI?
So that's a very good question. And I have to say that the MRI change, if it's present, I think it's really helpful for us. But sometimes in the early phase of your disease, actually MRI may or may not show the significant change. But nonetheless, that if we see the, let's say neurologist saw you and then they notice that some physical exam finding to suggest, some cerebral involvement, we do still recommend some MRI study to try to get the baseline because we can use that for the reference. And then let's say unfortunately, let's say you have noticed some like a worsening in the future, we can somewhat to go back. And so, I'm going to say MRI is not always so critical in terms of the diagnostic standpoint, but it can be still useful as a supporting testing. And in the research field, we do still use the MRI to try to kind of somewhat to determine some of the therapeutic effect in conjunction with the other clinical like outcome measurement. So
one tool of the trade.
right.
And we have time for one last question. We have an attendee who asks, would you recommend mindfulness or meditation as a way to calm down the nervous system for people with ataxia? And this attendee shares that it helps her, and she just wanted to share that.
I think that anything that you can apply and then even like a meditation technique that I think if that's really, beneficial for you. And of course, the meditation, I don't see any harm to do this actually. And so I think these are as important compared to, let's say, let's say more like a so-called standardized like approach, like a PTOT speech and, etc. Because we also recognize that ataxia patient can have some potentially like a cognitive influence, which I didn't touch today, but we've been recognized more and more compared to more like a physical component. And that's partly because the nerves in the cerebellum do have a communication to the other part of the brain. So for those reasons, I think like let's say some of the meditation technique can be also useful if that's really beneficial for you. It may or may not work for everybody, but why not, right? Like if that's helpful, why not? I think that's just my approach here. So
Well, we are out of time for today, but Dr. Kisanuki, thank you so much for joining us and sharing your insight and expertise. We really appreciate it.
thank you very much for your time. Thank you for listening to my presentation. Bye for now.
Yes, and for everyone who was on this call, I hope that you enjoyed the last hour with us and learned something new about unknown ataxia with family history. Wherever you are in the world, good morning, good afternoon, good evening. Have a wonderful rest of your day. Take care, folks.